Good evening and welcome to tonight's webinar. My name is Russ Rowan. I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we'll try to get them answered during the webinar. Once the webinar is completed, you'll receive a feedback survey in your email. Please complete that survey, and once completed, you will receive your CE certificate. We have the fortune of having Dr. Bhide with us tonight. We're very honored and appreciate him taking the time to spend some time with us and share some knowledge that he has. And I'd like to take this time to introduce Dr. Bhide. Dr. Vinay Bhide is a board-certified periodontist who provides a full scope of surgical, periodontal, and dental implant therapy. Dr. Bhide has special interest in aesthetic and reconstructive periodontics. Dr. Bhide completed his DDS and MSc in periodontology at the University of Toronto. In addition to private practice, Dr. Bhide is a clinical instructor at the Graduate Periodontology program at the University of Toronto. He is also an adjunct assistant professor in the Department of Periodontics at UPenn. Dr. Bhide has lectured nationally and internationally and published on various topics related to periodontics and implantology. Once again, Dr. Bhide, we really appreciate you taking the time, and I will turn it over to you. Thank you.
Thank you so much, Russ, for that kind introduction and also the invitation to give this webinar. As we were talking earlier, I'd mentioned to you how for a long time I'd been thinking how I would love to have the opportunity to share with everyone the experience that I've had with porcine peritoneum collagen membranes, in particular the Zmatrix membrane, which we'll be essentially showcasing tonight in this webinar. So thank you all for joining me and us for the next 50 minutes to an hour or so. I hope that by the end of this presentation that you will have picked up at least a few pearls that you can apply in your practices tomorrow, whether in thought or whether in action, and certainly do take advantage and answer or ask me as many questions as you can. I have really no time limit. Whatever time limit Osteogenics has set for me is what I'll abide by. So with that being said, let's get started. So as you all know, this webinar is hosted and sponsored by Osteogenics, and Osteogenics is a company whose products I have been using in my practice for a great many number of years. And tonight in particular, we'll be focusing a lot on this really unique barrier membrane called Zmatrix. Now, that being said, I have full creative control over every single slide in this presentation. There's no messaging that I've been told that I have to say. This is purely my presentation with my experiences, and I've not shown any investigational or off-label use of any biomaterials that I'll show you today. And I've not made any misrepresentations of any photography. There's been no Photoshop or manipulation of any kind to misrepresent any of the results. Yes, I have cropped, I've maybe brightened and lightened and whatnot, but the results that you see are exactly as I've seen them clinically. Now, as Russ mentioned, I am from Toronto, born and bred in Toronto. For those of you who've never been, I always have to give a shout out to my beautiful city. It is really an incredible city. And this, what you see here in the picture, is the skyline that's punctuated by one of the tallest buildings in the world, the CN Tower. And right beside it, it's the Rogers Centre, formerly known as Skydome, where we have a lot of concerts. The Toronto Blue Jays play there as well. So please do visit Toronto in the summertime, especially because it can get nice and hot and humid. And if that's your jam, then you're going to have a great time. And especially if you like food, Toronto is one of the foodie capitals of the world. We also have all the sports teams represented, from the Maple Leafs to the Jays to the Raptors. Admittedly, we've been disappointed the last few years by all of these teams. But, at least we have Drake that will always, put a smile on our face in the event that our sports teams are not winning championships. But in all seriousness, really, it's a beautiful city, so do come visit. I practice in the small town suburb of Aurora, which is about 20 miles or 30 kilometers north of the Greater Toronto area. The best part of Aurora is that it's like the small big city or the big small city nestled amongst a whole bunch of smaller communities. So we are just far enough away from the urban center of Toronto, where we don't have to deal with all the riffraff that the big city has to offer. But at the same time, we're close enough that we can enjoy all the best of the city. So I work in a group practice called the Aurora Periodontal Center, and I'm really lucky to have this incredible collection of human beings, which I'm proud to call my staff. It's really because of them that I am able to do what I love to do, and especially to do it at the level that really my patients deserve. I'm blessed to be able to work with 4 other periodontists who are more so than talented clinicians, they're even better human beings. And 2 of them, the 2 gentlemen to my right in the photo, are my classmates from dental school. We've known each other since 1997. We did our hospital residency together, and then we decided to specialize together because we just loved each other so much. And in 27 years of knowing each other, we've never gotten into a single argument. Yes, we've had our disagreements, but the beauty of working in a group periodontal office is that you've got a second opinion right next door, and the patients love it because they appreciate the fact that we're humble enough to ask our colleagues for help or an opinion if we need to. And so it makes for a really good working environment. The camaraderie is fantastic. And we all have our interests and our strengths and our weaknesses. For example, I really am into the reconstructive side of things, whether it's soft tissue or bone grafting, bone reconstruction. Another one of my colleagues, he's more into the full arch dental implantology. And so we're always leveraging each other's experience and knowledge base to be better clinicians ourselves. So really unique working environment. And for any residents who might be watching today, really be good with your classmates because you never know, you might end up working with them one day. So it's really, really a pleasure for me to do this. What are we going to talk about this evening? What are we going to learn? So we're going to learn a lot of things. I mean, certainly bone grafting is a wide topic that I can spend probably an entire weekend on. But in the next 50 minutes or so, we'll really distill the essence of what I feel to be what you need to know to be able to apply in your practices tomorrow. So we'll talk about what are the various factors for achieving successful and predictable augmentation of deficient ridges. And in this presentation, we'll focus exclusively on horizontal ridge augmentation. Vertical augmentation is a whole different ball game with a different material set. And perhaps it's another lecture for another day. But we'll be focusing the crux of this presentation really on the role of barrier membranes and what they do for facilitating regeneration. Okay. And we'll talk specifically about Zmatrix porcine peritoneum collagen membranes. We'll look at the indications, the rationale, and I'll take you through step by step my approach for how I achieve predictable GBR outcomes. And you'll see that all the cases that I show you in my presentation today are done more or less in exactly the same way. I try to find what works for me and then just keep repeating that like a tried, tested, and true formula for success. And like I said, we will be focusing specifically on the barrier capacities of Zmatrix, as it does have some unique biologic, physical, and handling properties, which I've really come to appreciate over the last 5 years or so that I've had the opportunity to use this product. Private practice is very much an evolution, and certainly for me in the area of bone reconstruction, it's taken me time to really figure out what works well in my hands. And I've learned a lot of things the hard way, by trial and error, by talking to colleagues, by going to conferences. And one thing I've come to appreciate that is that a lot of us, you can talk to 5 of us, and 5 of us will have different recipes or different cocktails that we use for success. And what I'm presenting to you today is not just me using a particular barrier membrane to get great results for bone grafting, but it's really showing you the evolution of how I've come to select the various products or techniques or materials that have worked for me over the years. And I continue to refine my technique. I continue to learn more, and as things change, incorporate these changes into my practice. We learn a lot from our successes. We learn even more from our not so successful results. So that being said, let me introduce you to 3 key concepts that really guide me in my private practice. One is success, the other is predictability, and perhaps most important is the concept of reproducibility. So we hear these words all the time, success and predictability. So what is success? Success is our ability to achieve a particular favorable outcome But success can be a one-time thing. Okay, so for example, everyone who knows me knows how much I love doing free gingival grafts. In my humble opinion, it's one of the most predictable, successful techniques for root coverage in the anterior mandible. So a successful outcome would be my ability to achieve complete root coverage for tooth number 24, for example. Now, if I was to do this once but never again, then I'd be having success, but the procedure would not be very predictable. So predictability really then refers to our ability to achieve a particular successful outcome a high percentage of the time. So let's say I'm able to now achieve this particular outcome 70, 80, even 90% of the time. Then that makes that particular procedure predictable. Just like the free gingival grafts, I can do this all day long in the anterior mandible, and I know what type of result I'm going to get. But perhaps more important is reproducibility. We've all been to courses, we've all seen lectures where the lecturer gets everybody enthused and excited about a particular technique, a particular material, and how he or she can obtain an incredible result, only to find out when we go to our practices the next day and try this technique that 6 months later, we don't seem to get the same result that the speaker talked to us about. That happens a lot in dentistry. What I'm going to show you today is something that I believe to be reproducible. I do not have magic hands. I do not have fairy dust emanating from my fingers. The results that I'm showing you are results that anybody with some surgical acumen can achieve in their private practice. Okay, yes, this does require some reps. It requires some experience. But that being said, I'm going to show you in a very, very systematic way how to achieve successful, but more importantly, predictable and reproducible horizontal guided bone regeneration outcomes. So just like with the free gingival graft, wouldn't it be nice if we were to take a ridge like this, as highlighted in this photo, and turn it into a ridge where we have a lot of bone growth available for implant placement? Okay, this is what just like I can achieve successful and predictable outcomes with free gingival grafts in the anterior mandible, I would love to achieve predictable horizontal bone regeneration in my practice as well. And again, this is very much for me, it has been an evolution. It has been trying various things and figuring out what works for me. So as they say, all roads lead to Rome, or supposedly all roads lead to Rome. But you can also say that many roads lead to bone. Okay, and some of you that are watching may have a very tried, tested, and true way of bone regeneration. And if you do, that's great. Stick with it. I'm just showing you a different way of doing things that perhaps may stimulate or inspire you to try something different in your practices, or maybe try something for the first time because you may not be having the results that you want with regeneration of bone. In order for us to achieve successful regeneration of bone, we need to be cognizant of what we call the regenerative triad. We need to have signaling molecules. In the case of bone regeneration, that refers to osteoinductivity. We need a scaffold, which refers to the property of osteoconductivity, and we need to have appropriate cells. Ideally, we'd like to have osteogenic cells, such as osteoblasts, as part of our bone grafting cocktail. And as you can see, all these three bubbles are not mutually exclusive. They are overlapping, they're synergistic, they're acting with one another. We need all three of these things, the inductivity, the conductivity, and the genesis, working together over time to affect positively tissue and bone regeneration. Okay, so signaling molecules, scaffold, appropriate cells. If we have all three of these things, that's a pretty broad recipe for successful tissue and bone regeneration. So now we look at this picture again, where we've taken a ridge that was deficient and augmented it to the point where we have tons of bone. And yes, this makes for a great post and a great picture on Instagram. But growing bone in and of itself is not the end goal here. It's just part of the process that the patient goes on. Okay, what we really want is to grow enough bone and grow enough bone in such a way that we can place implants in a prosthetically favorable location that are also surrounded by a good bony infrastructure, because we know that we need to have at least 2 to 4 millimeters of bone, at least on the buccal aspect of implants, to prevent the risk of crestal bone loss, thereby preventing peri-implantitis in the long term. Okay. Of course, we're going to restore that implant, or my restorative colleagues will restore that implant. And if we do everything prosthetically driven, then the ultimate goal would be to have screw-retained prostheses, which have the built-in property of retrievability, right? So all this to say that implant therapy should be prosthetically driven. We should be looking to our restorative colleagues to be the quarterbacks, to be the greatest quarterbacks of all time, to be able to give us the prosthetic prescription. So as a surgeon, I know exactly where I need to place these implants to get the most optimal and favorable result. So don't just place the implants, okay, where there's bone, right? Make sure there's bone where the implant needs to be. So with guided bone regeneration, this technique has been around for a long time. It was first introduced formally by Dan Boozer and colleagues in 1990. So we're going on about 34 years that GBR has been known to the world. And over the years, there's a whole host of literature showing how successful and predictable it is for both horizontal and vertical augmentation. Now, admittedly, there's more literature in the space for horizontal bone regeneration, but over the last 15, 20 years, with the work of people like Dr. Isht van Urban, we now know that vertical augmentation as well can be quite predictable. And all you have to do is follow proper fundamentals and principles of bone biology and respect bone healing. So the concept of GBR is very similar to the concept of GTR, which is guided tissue regeneration around teeth. Now with GTR, we're trying to regenerate cementum, periodontal ligament, and alveolar bone, 3 distinct tissues. With GBR, we're just trying to regenerate bone. So in theory, it should be easier, maybe less complicated, less complex than GTR. And the central piece to a lot of this is by using the barrier membrane. The barrier membrane essentially protects the regenerating wound from coming into contact with the epithelial and connective tissue cells from the overlying flap. Because if these 2 cell types are able to enter the healing wound, then we get healing by repair. We get healing by long junctional epithelium, and it compromises the amount of bone quality and quantity that we have available for implant placement. Now, that being said, we need a barrier membrane that can maintain space, and not all barrier membranes are form stable. Not all of them have stiff properties or titanium backing. In fact, most of the membranes we use in GBR are softer membranes made of collagen. So we rely on some type of allograft or xenograft particulate bone used underneath this membrane to help support that membrane and maintain the space. We know that there's a variety of materials available to us at our disposal. Like I said, you can ask 10 different clinicians what they use, and you'll get 10 different cocktails for their clinical practice. Now, the important thing here is that before you decide to use any particular material, make sure that there's good literature, there's a good evidence basis for this that will help you in your private practice. Because the last thing you want to do is use a material that looks good in theory, but in the end does not give you the results that you want. And then, of course, GBR is a much more elegant way to achieve bone regeneration and much less morbidity associated with it than the traditional methods like block grafts from the iliac crest or the chin or the ramus. Okay, as you can imagine, those procedures can be quite invasive. There's also some pretty significant sequelae that can occur with those, such as with chin grafts, there's almost a 10% risk of devitalizing the mandibular anterior teeth. With GBR, you're really not at risk of devitalizing anything. Yes, there are certain anatomic nuances that you have to be aware of, such as where the mental nerve is, et cetera, but it is a much less morbid procedure, and it's quite predictable. And philosophically, I think as clinicians, we follow this mantra of first, do no harm. So we really owe it to ourselves to figure out techniques that really serve us in terms of being able to achieve the outcomes that we want, but at the same time, having for a very good, comfortable patient experience, right? Nobody really enjoys the prospect of having surgery. So at the very least, we can make it more comfortable for our patients. And GBR affords us the ability to do that. As we know, in order for successful bone regeneration in particular, we've talked about the regenerative triad. Yes, we need signaling molecules, a scaffold, and appropriate cells. But as far as the technique of bone regeneration itself is concerned, if we follow this PASS principle that Hamle Wang published a number of years ago, we likely will get excellent results. So the P stands for primary closure, not just primary closure, but we need tension-free primary closure. That is the key. If we have tension in our closure, what happens? What happens is that the wound wants to spread apart during the healing, and that can lead to exposure of the regenerating site, can lead to compromised result. We want good source of blood supply. And so this is where patient and case selection becomes very, very important. Smokers typically are not good candidates because the smoking impacts blood supply. Furthermore, patients that are medically compromised may have conditions that compromise their angiogenic capabilities. So blood supply, the ability for angiogenesis is very, very important. As I mentioned earlier, we need space maintenance, and that we can get with our particulate bone grafts covered up with our membrane. And then we want this entire complex to be stable, because if there's movement, then that will create enough space for epithelial and connective tissue cells to get into that area, and we get healing by repair, i.e. long junctional epithelium. And that will definitely compromise the amount of bone that's regenerated. So here's a case where I'll show you my step-by-step technique for how I achieve predictable horizontal GBR outcomes. So this patient had lost teeth number 18 and 19. For the Canadians watching, 3.6 and 3.7. She'd lost these teeth at least 10 plus years ago before she came to me. And she was interested in implants. She'd never worn any type of partial for replacing these teeth. But as she got on without these teeth, she felt that her ability to chew and enjoy her food was compromised. She was in her 60s. She had controlled hypertension. She was on medication like Ramipril, and otherwise healthy, non-smoking individuals. If we look at the cone beam CT scan, first clinically, just appreciate that this ridge has some significant resorption clinically. And the CBCT, you can see if you look on the right side, you can see that obvious area of buccal ridge concavity. There is also perhaps a mild vertical deficiency as well, but not enough that we'd really care to augment this vertically. This is more of a horizontal augmentation case. And one of the things that we need to do is we have to be able to classify our ridge defects. And before we get to that, I just wanted to show you some more views of the cone beam CT scan. When we look at these cross-sectional images, you can see that the bone morphology is more or less pear-shaped. Now, some people might be looking at these scans and say, hey, you know what? Maybe we could place an implant and do simultaneous augmentation. And that's fine. There's certainly evidence to support that. However, as I've gotten on with my experience, as I've gotten on with doing this daily in my private practice, I've come to realize that when it comes to implant dentistry, slowing things down is never going to hurt you. I find that taking a more conservative approach, doing one thing at a time, but doing it well, has served me better than trying to do multiple things at the same time. Patients been missing your teeth for 10 to 15 years. So having to endure 1 year of treatment versus 6 months of treatment is really not a big deal for this patient. So my philosophy with these type of cases is grow the bone first so that I can put the implants into solid bone at the appropriate time. Okay, and you can see that this patient has bone which is not very dense. In fact, there's a big medullary cavity that's surrounded by the cortex. So I often use a Siebert classification of ridge defects where we have 3 classes, class 1, class 2, and class 3. A class 1 Siebert deficiency is one which is purely horizontal in nature. A class 2, we have good horizontal width, but we were lacking dimension vertically. And a class 3 is a combination horizontal and vertical deficiency. And as you can imagine, as you go from class 1 to class 3, the complexity of the case certainly becomes more and more. Now, notice I didn't say predictability becomes less and less, right? Because we have the tools now to be able to treat all class 1, class 2, class 3 in somewhat predictable fashions if we follow proper surgical principles and respect the biology of bone healing. As I mentioned to you, maybe 10 years ago, I would tell patients that vertical augmentation is just not predictable anymore. But certainly we've seen people like Dr. Ish van Urban and others that have shown this to be absolutely predictable. You just have to be able to change your technique to be able to accommodate for that. So then for this particular patient, we'd classify this defect as a Siebert class 1 with a mild vertical ridge deficiency. So I did not call this a Siebert class 3 because my objective here is to treat the horizontal deficiency. I'm not really so much concerned about the vertical, but I must acknowledge that there is a vertical ridge deficiency there. So first thing we're going to do is start with our incisions. I typically like to do an incision design where I go one tooth on either side of the edentulous space. I make my remote vertical releases. So in this case, I did my vertical release on tooth number 20 and tooth number 17, I guess it is. Sorry, I'm not familiar as much with the American system, but nonetheless, we do our vertical releases, and then I come paracrestally, and note that I'm going to make my incision to preserve as much keratinized tissue as I can. Okay. So next we have our flap elevation, our flap reflection. I typically will go full thickness as far as I can, making sure that I identify the important anatomic structures. The mental nerve is somewhere near the bottom of your screen, but you can see that there's good clean bone there. I spend a lot of time at this stage debriding the bone of any soft tissue tags. So you can do that with an extraction curette. You can do that with moist gauze that you burnish along the bone surface, but you can see how nice and clean that bone is. Step 3, okay, we will, and this picture again, you can see the extent of that deficiency. Step 3, what I do is I take a bone scraper. Unfortunately, in Canada, we can't get the disposable bone scrapers, so I have to use these autoclavable bone scrapers. But the point here is that we scrape bone from the ridge that we're grafting. Because again, one of the things that we want in our roadmap for regeneration is a source of osteogenic cells. And what are those? Those are osteoblasts. They're direct bone producing cells. So I scrape the cortical surface of the area that I'm going to graft. At the same time, I achieve decortication, but I also get these nice bone shavings that I can then mix in with my particulate allograft. And my particulate allograft of choice is a mineralized cortical cancellous particulate allograft. So I make this composite bone mixture with the autogenous bone scrapings. Now, I'm a creature of habit. I still like to do cortical bone perforations. Even though the literature says that it may not make any difference, I think that there's certainly no harm to it. And if anything, it gives you a nice source of undifferentiated cells that when they come into contact with the bone conglomerate that we're going to graft the ridge with, they will attach, they will differentiate into osteoblasts. So you'll get even more bone formation. So again, I do believe in the power of cortical bone perforations. You don't have to go crazy, but enough cortical perforations to get good bleeding points is sufficient. And then what I like to do is I like to get all my flap releases and everything out of the way. So I'll do my buccal flap release at this time, but more importantly in the posterior mandible, I'll do my lingual flap release as well. Because if I wait until the end of the procedure to do the lingual flap release, I find that there's more bleeding that I have to manage. So better just to get it out of the way. Lingual flap release before used to scare me. It doesn't scare me as much anymore because I could do this exclusively with blunt instrumentation. I can use the back end of my P24G or my Boozer elevator and gently dissect this flap off of that ridge. And you can see that it just elevates very, very easily. And typically, if I can elevate that flap at least above the coronal aspect of the adjacent teeth, then I know that I've released pretty well enough for me to get tension-free primary closure. And don't forget that you're also going to be releasing the buccal flap as well. So you have two flaps that are released and passivated. And this is why horizontal bone regeneration works really, really well in the posterior mandible as well as vertical augmentation as well, because you have two flaps that you can get some really good mobility from. Step 6 is the actual ridge augmentation. So now I take that composite bone mixture of the cortical autogenous scrapings and the particulate allograft, and I carefully graft this ridge. I want to try to reconstruct the original dimension of this ridge from before when the teeth were removed. I always want to overbuild a little bit because I do anticipate that there's going to be some loss of particles or some shrinkage during the bone healing. So if you think you need 6 millimeters of ridge width, graft to 8 or 9 millimeters. And if you don't get a lot of shrinkage, then that's a bonus. But if you get some shrinkage, then you'll at least have enough to be able to place an implant into. The next step is to trim and adapt your barrier membrane. So here you see on the inset, my Zmatrix Porcine Peritoneum Collagen membrane. I've trimmed this in such a way that I can tuck it in on the lingual aspect, and then it just drapes over very, very nicely onto the buccal aspect. And you can see how intimately that membrane can drape over the bone graft. And I've not used any stabilization sutures with this membrane. And in fact, this is one of the reasons I really, really like this membrane, is because I seldom have to actually use stabilizing sutures or tacks to get good horizontal augmentation. Okay, there's no side of orientation for this particular barrier, and even if it comes into contact with the adjacent teeth, that is quite okay. All right. One thing that I do now is that I've become more confident with this membrane over the last 5 years or so that I've been using it. I tuck it into the lingual or palatal aspect, and then as it soaks up with the patient's blood in the area, you can start pushing it over onto the buccal. And then you just let it sit there and let it soak up some more blood on the buccal aspect, and then take your cotton plier or the back end of a periostal elevator and just gently tap it down into the area. And it just adapts so very intimately to the graft. The other thing that I've started doing is I've had my assistant take saline in a syringe and gently just wet the area to passivate that membrane even more. So what are we looking for in a barrier membrane? I mean, barrier membranes come in all shapes and sizes. And if we follow this from the upper left in a clockwise way, we can see that we've got a pericardium membrane followed by a titanium reinforced membrane. We've got our Zmatrix on the upper right corner. On the lower right corner, we see another native type 1 porcine collagen membrane. In the middle on the bottom, we have an amnion-chorion barrier membrane. And last but not least, on the lower left side, we've got our ribose cross-linked collagen membrane. These are all membranes that have been used very commonly in private practice. And I've certainly used every single one of these membranes and have had my share of mixed results with a number of them. That being said, they all serve a very similar function, and that is to prevent epithelium and connective tissue cells from coming into the wound. Now, some may work better in my hands than they might work in your hands, and vice versa. But the bottom line is that there is a variety of barrier membranes out on the market today. And you owe it to yourself to try all these different membranes, because it's only through trying them that you'll see which membranes are actually easy to work with every single time. So what are we looking for? We're looking for a barrier membrane that is biocompatible, one that doesn't elicit a strong inflammatory response from the body. Okay, most of the membranes on the market today are biocompatible, but not all of them have the same minimal inflammatory response. Zmatrix, the healing of it is such that I find it has very, very little inflammation, even when I call my patients back at 1 week or 2 weeks. We want a membrane that can occlude epithelium and connective tissue cells. Okay, it's a very, very key concept in membrane science. But we also want membranes that don't exclude nutrients from the surrounding area to get to the bone graft. We just want them to exclude the epithelium and connective tissues. We want a membrane that can be easily incorporated and integrated by the host tissues. And certainly I find with Zmatrix that because it is biocompatible, it is integrated very, very well. This is why we have a very minimal to no inflammatory response, even at 1 week or 2 weeks. Clinical manageability, as I've shown you, what more do you want from a membrane that drapes so nicely over your graft material? I'm a pretty simple guy. I tend to be very lazy. I don't want to do more steps than I have to do. And so a membrane that I don't have to secure with tacks or secure with sutures most of the time is something that's very, very appealing to me. We want a membrane that can maintain the space. Now, collagen membranes on their own can't maintain a space without having some allograft or xenograft or a mixture underneath them. we want a membrane that has favorable mechanical and physical properties. By that, what I mean is we want a membrane that we can manipulate in the site itself. One of the membranes that I showed you, a couple of the membranes that I showed you on the other slide, the moment they become wet, they become very, very difficult to handle. And so you have to handle them dry until like the very last minute. Whereas I find with Zmatrix, I can actually manipulate it, handle it, even if it gets wet with the patient's blood or saline. So it handles very, very well. It also doesn't resorb very quickly. It's going to be around for at least 4 months, which is really, really good to get through that first half, at least, of the bone regeneration process. Remember, bone regeneration takes time. There's osteoblastic activity that's still happening at about 8 or 9 months. And this is why I don't rush to go back into my GBR sites. I wait typically 6 months before I go back. So I need a barrier membrane that's going to be there for at least 4 to 6 months. So getting back to Zmatrix, what makes Zmatrix unique? So here's a slide that I want to show you on the properties that you need to know really about Zmatrix. So it is non-cross-linked peritoneum collagen membrane. It is derived from a porcine source, and it is natural. And this property of being non-cross-linked as well as coming from the peritoneum gives it this unique elastic property. So even if you were to use tacks, you could stretch out that membrane very, very nicely. As I mentioned, I don't really use tacks or stabilizing sutures for this particular membrane, but I certainly see the elasticity of it. There's no question that it is one of the best membranes to intimately adapt and drape over the area that you're trying to regenerate. And the thing that I really appreciate is that even if it gets wet, the game is not over. You can still manipulate this membrane, tuck it in, you can kind of unfold it, you can drape it over itself, you can do whatever you need to, even in its wet state. The thing I really, really like about this as well, from a biochemical perspective, is that it's just not a collagen membrane. It also contains some really, really important factors from the extracellular matrix that aid in wound healing, such as laminin, fibronectin, elastin, which gives it the elastic property, as well as a bunch of glycosaminoglycans, such as decorin, which is very, very important for organization of collagen fibrils. Laminin in particular is very, very interesting because laminin actually promotes migration of epithelial cells over a wound. So if this membrane happens to get exposed prematurely, I don't worry a whole lot, because what happens is that the laminin that's exposed on this membrane kicks in effectively, and you get good migration of epithelium over that area. So you don't have to take it away, you don't have to babysit it a whole lot. It has got these other biological matrix molecules that really, really enhance its wound healing capabilities. And again, as I mentioned, it's substantially resorbed. It sticks around for at least 4 or 5 months, but I think 6 months is a pretty reasonable average time. And this is why I typically don't enter my sites for at least 6 months. So getting back to our case here, step 8 is closure. And as I mentioned, we need tension-free primary closure. I like using the bilayer technique, which involves using interrupted sutures alternating with horizontal mattress sutures. And you can see from this picture that the wound edges are everted, because what happens in the initial phases of healing is that the wound wants to retract. So with the bilayer technique, when the wound retracts, the wound edges will still stay together. And this is what makes this technique of suturing so very effective and prevents a lot of retraction that we would otherwise see if we didn't use this technique. And then we wait for, I said, minimum 6 months. And you can see that the healing is really, really nice. It's really, really clean. When we look at the occlusal shot, we can see it looks like almost nothing was done from the surface. But you know that there's been some good bone regenerating under there and cooking over these last 6 months. So what do? I send my patient again for a cone beam CT scan. And you'll remember what the initial cone beam CT scans looked like. And you'll appreciate this difference in ridge contour that's on the buccal that we've been able to regenerate. All this bone, I think I've even managed to get a little bit of vertical augmentation here as well. Now, people will look at this and they'll get very excited, right? I don't get very excited when I see these CBCTs. I mean, yes, I'm happy that I see that there's bone there, but until I actually get into the site and see what that bone quality is like, I tend not to count my eggs before they're hatched, because I've been burned times a number of times in the past where I see this amazing looking CBCT and then I go in and the bone's very soft. Okay, but when you see something like this, which looks relatively seamless, chances are you'll be happy at the time of reentry. So here we go. Here's the reentry, and we can see some really good regenerated bone. Looks like it's native almost. It's nice and bleeding, and when I drill into it, it feels just like type 2 bone. So the next step would be to place our implant. But look at this regeneration that we've been able to achieve from preoperative to the reentry. It's pretty substantial what we've been able to do. So now we put our implant in. In this case, I used a trabecular metal implant, and we can appreciate the buccal bone shelf that we have on this implant of at least 2 to 3 millimeters. And I know that this is going to serve this implant very well in the long term as a hedge against crestal bone loss and periimplantitis. And radiographically, we see good bone remodeling at about between 6 months and a year. We've got a nice tissue contour on the buccal and a screw-retained crown. We did give the patient the option of getting 2 implants, but financially it did not permit her to do so. So we did a single implant with the hope that hopefully one day we'll be able to use all that bone that we've regenerated to put in a second implant. Now here's a case of a guy named Gary. Gary is a fellow that was in his mid-70s. Now he's in his late 70s. Very, very healthy guy, good-looking guy, non-smoker. He'd been having this bridge in the lower right side for many, many years, at least 30 years by his estimation. And finally, this bridge failed. You can see that there's recurrent decay underneath that distal abutment tooth. And it's a long span bridge. It's pretty amazing that this bridge lasted in the posterior for this many years. So the treatment plan for Gary was to remove the bridge, remove the decayed abutment tooth, and to do some horizontal ridge augmentation, GBR, to place a couple of implants, which would then be restored with splinted crowns. What's interesting is in the radiograph, you can even see that there's been a remnant of the old root canal that's been left behind that we're going to have to clean up as well. So we got CBCTs for Gary, and you can see there's no way that I'm going to be able to put implants into a bone with this type of ridge morphology. This is narrow, the bone isn't where I want it, so this definitely calls for a horizontal augmentation. We've got tons of height between the crest of bone and where the mental nerve foramen is, or where the inferior alveolar nerve canal is. So really, we need to effect pure horizontal augmentation here. So again, I start with my incisions. I go 1 tooth on either side for my remote vertical incisions with a paracrestal incision, preserving as much keratinized tissue as I can. I then do my flap reflection and identify important anatomic structures. And you can also see where this old remnant of the root canal was left behind. When I look at this from an occlusal view, you can definitely see where that ridge deformity is. So I'm not really going to be able to place implants in this bone unless I do some augmentation. So we'll do some horizontal GBR, and at the same time, we'll do a socket preservation of that distal abutment as well. Once again, I take my corticocancellous particulate allograft with my bone scrapings and mix this all together. Okay, so this is no different than what I showed you in my previous step-by-step case. Okay, so what I'm showing you, I do the exact same thing every single time. I then make my cortical perforations because, again, I think that there's more benefit than anything. There's really no harm in cortical perforations. If anything, like I said, you get this other rich source of cells that will differentiate into osteoblasts upon coming into contact with the bone particulate material. Now, the only thing that I did differently for Gary, because this was one of my earlier cases using Zmatrix, was, and back then I would actually wait until the end to do my flap release. Okay, so now in this case I would do my flap release at the beginning of my procedure, shortly after my cortical perforations. But in this case I'll do it after, and that's fine. I augmented the ridge with this particulate mixture, and you can see that we've overbuilt this. And then I take my Zmatrix, I tuck it in on the lingual, and I drape it over very nicely onto the buccal. And you can see that there's really some excellent adaptation and draping, such that why even bother now putting stitches in? Because if anything, that's going to put more tension on this membrane. I'm just using this membrane as a protective layer. I go ahead and do my lingual flap release, and I think I've achieved in more than enough. And then I get my tension-free primary closure using the bilayer technique. Okay, re-entry again at 6 months, the healing looks very good, but this is what we see when we raise our flap. We've regenerated all this bone, and this bone looks really, really native. I would never know that grafting was done if I hadn't done the grafting myself. We place a couple of implants in this bone that we've created, okay, and just, again, appreciate how much bone we've been able to regenerate from the pre-op to the re-entry. Implants get placed with a nice buccal bone shelf. We put healing abutments on, close up, and then ultimately these implants get restored. And this is what it looks like at 3+ years in function. We have good, nice keratinized tissue. We have screw-retained, splinted crowns, which the patient is maintaining really, really well. And bone is remodeled to the first thread as we'd expect. And it's pretty stable for 3+ years in function. Now, Gary had the same problem on the other side, where he had another bridge with failing abutment teeth. So again, the plan here became to extract these teeth and to do a GBR procedure and place 3 implants that would then be restored with an implant-supported bridge. So again, his CBCTs on the left side look very similar to what they looked like on the right side, in that there's good height to the alveolar nerve canal, but we need to build up the ridge width. So we extracted the teeth, and you can see that there's been buccal bone dehiscences in all these areas, and in the area where there's pontics for the bridge, it's quite deficient. And we have to graft this entire area. So again, I do my cortical bone shavings with my cortical perforations, mix it in with my particulate allograft, and really, really build up that ridge nicely. I then take my Zmatrix and again, drape it over. No need for stabilizing sutures here because the membrane is so intimately adapted to the graft, okay? And it's stable, okay? I get my buccal and lingual flap release with my bilayer tension-free primary closure, and you'll see that I flip-flop here between glycolon and PTFE sutures. My preference is glycolon. It's just I find it's easier to work with, and it does resorb over a longer period of time. PTFE's been great as well. It really is your personal choice. And then this is what the reentry looks like at 6 months. Pretty incredible, okay? Like you could park as many implants as you want to into that bone, okay? So this is what we did. We placed 3 implants with good buccal bone shelf on all of these implants. And I was so delighted with how much bone I grew that I really didn't pay attention to the soft tissue. So this is the problem. When you grow so much bone, you start patting yourself on the back, but you also have to think about the soft tissue as well. And here's a radiograph at the time of implant placement. And the patient got these implants restored. And after about a year in function, the patient developed a dehiscence on the most anterior of these implants. So what do we do now? We have to treat this. So what do I do? We did a free gingival graft to try and build up the zone of keratinized tissue. And this is what the implants look like now at 4+ years in function. Okay. Now, looking back in retrospect, I probably should have done this soft tissue augmentation when the implants were replaced. Okay. And radiographically, we have stable bone levels as well. So last case I want to show you is a case where I'm reconstructing a site of a previously failed implant. So this patient had this original Calcitech implant in function for about 25 years. And as you can see, developed some significant bone loss and peri-implantitis. And there's no way really that we can salvage this implant. So we decided to remove this implant, graft the area with the view of placing another implant. So I raised my flap, and you can see the granulation tissue here. We debrided the granulation tissue so I can show you the extent of bone loss affecting this implant. We explanted, and what we're left behind with here is a pretty substantial deficiency on the buccal, and we can also see some proximal deficiency as well, particularly towards the second premolar. So we have a peak of bone on the mesial, not so much a peak of bone on the distal. So this represents a challenge, and some of us may use a titanium reinforced membrane here. But I decided that I was going to think outside the box a bit, and I used a particulate allograft, grafted this area, put my Zmatrix membrane over the top. And in a case like this, again, you can see how nicely that membrane drapes over the graft. I use stabilizing sutures here because of the vertical nature of the augmentation. Okay, so in a case like this, I would use a simple cross mattress suture to keep that membrane in place. We then get tension-free primary closure over this graft. And then at 6 months, I go back. You can see very, very clean healing here. We open up the area. After we see this radiograph that we've taken that has looked like it's got nice mineralized bone. And this is what it looks like once we open it up. We've got nice bone that we've regenerated. We've got an implant in with good buccal bone shelf, with good insertion torque value, 35 Newton centimeters, put a healing abutment on there, and then send the patient for restoration after about 4 months. Okay, and this is what the radiograph looks like at the time of placement. At 4+ years in function, we have an excellent result with good soft tissue, good peri-implant tissue health, and radiographically, we can see nice stable bone levels as well, right? So growing bone is one thing, being able to place an implant in the bone is another thing, but having that bone stick around for the long haul is actually probably the most important piece of the puzzle. So some final thoughts and reflections here is that I've hopefully been able to show you that successful, predictable horizontal GBR can be achieved with the porcine peritoneum collagen membrane, also known as Zmatrix. And the one defining feature of this particular membrane is that fixation with tacks or sutures is not required for the vast majority of your horizontal augmentation cases. So it eliminates an extra step, an extra factor of complexity. Again, it's not just all about growing bone. It's about placing the implants in prosthetically determined location within that bone, also paying attention to the soft tissue infrastructure around the implants. You know, in the last case I showed you, we got tons of bone, but the soft tissue wasn't good. So we had to rebuild that after the fact. And case selection is key. GBR works beautifully on patients that have contained bone defects, patients that are not smokers, patients that are otherwise healthy. Also knowing what the defect classification is will also guide you in terms of your material selection as well. Okay, so with that being said, I hope that you've enjoyed the last 50 minutes or so. You've learned at least 3 things that you can take back to your practices tomorrow. And I want to end with this quote from Dr. Maya Angelou, you know, do your best until you know better. Then when you know better, always do better and always do better every single day so that you can give your patients the best possible outcomes. So with that being said, thank you once again for all of you for taking time out of your Tuesday to listen to me speak. Thank you to Russ and Stephen and the team at Osteogenics for giving me the opportunity to share my experiences with you. Please follow me on social media if you're not doing so already. And here's my email as well that you can keep in touch with me and ask me any questions or if you need any guidance on any cases that you might be doing. And with that being said, I will stick around for as long as you want me to answer questions.
Thank you, Dr. Bhide. We do have some questions that came in, so if you'd be so kind, I'll start with the first one. Which side of the Zmatrix membrane faces up or down? Does the orientation matter?
As I mentioned, the orientation doesn't matter. There seems to be sometimes one side that looks a little bit more uniform, another side that looks a little more textured, but that's just a byproduct of the manufacturing process. I do not believe that there is an orientation that you have to follow. So either up or down, whatever is up or down to you, that's what matters.
How does the Zmatrix membrane differ from BioGuide, especially in terms of handling if you have experience with both?
Okay, so I was trying not to mention product names here, but since you asked, I will answer the question. So the difference between Zmatrix and BioGuide is that when BioGuide becomes wet, it becomes very, very difficult to handle and manipulate in the site itself. You have to put it in dry and then be very careful that you don't get it too wet. Whereas with Zmatrix, you can put it in dry, and even if it becomes wet with the patient's blood or with your saline, you can still manipulate it, you can unfold it, you can uncrease it, and that to me is the biggest advantage that it has over a membrane like BioGuide.
What sutures do you use for these cases, and how do you decide which sutures you're going to use?
So again, I'm a creature of habit, and I've landed on 5-O-glycolon for the vast majority of these cases. I like glycolon because it is a slow-acting, resorbing suture. It's very easy to work with, and it doesn't irritate the patient's lip and mucosal tissues. And so I use that for pretty much all of my GBR cases now.
Would you consider going in at 4 to 5 months to add a free gingival graft to the buccal to increase the zone of attached gingiva prior to implant placement? Do you think this would alter in any way the regeneration of the bone at this time?
Great question. what I would do is I would first place my implant. I would first do my GBR, place my implants, and then when the implants are 2 to 3 months into their healing, I would then do my free gingival graft to increase the zone of attached gingiva. The reason is because if I do my free gingival graft after 4 months of GBR, I don't know what the quality of the regenerating bone is like at that time. And also, I find the tissue becomes harder to manipulate at the time of implant placement, especially after doing a free gingival graft. So again, GBR, take advantage of the elasticity of the mucosal tissue when you're doing your implants. And about 2 months into the implant healing, you can always do a free gingival graft because by then you're not going to impact the bone in any way.
Is having a fold in the membrane problematic?
Small fold, probably not. I mean, some membranes are going to have a little bit of fold, but it's not really a big issue as far as I've seen in terms of regenerative outcomes.
Great. I have time for a couple more here. It's a good one. What is your protocol for 1 to 2 week post-op with these types of GBR procedures if primary closure has opened, if you have a dehiscence?
So if I have a dehiscence, so I always call my patients back after 2 weeks for their first post-op. I put the patients on antibiotics, I put them on anti-inflammatory for pain medication, and I give them a hyaluronic acid mouth rinse because I find that's very good for its anti-inflammatory properties. Now that being said, if there is a dehiscence with Zmatrix, I've not really had a dehiscence because of the flap release that we're able to achieve. Now, if I was to have a dehiscence, for example, I'm not so worried about Zmatrix because of the fact that there's laminin in that membrane. And so you'll get resolution of that dehiscence relatively quickly. Now, that being said, I will have the patients do saline rinses. I'll have them rinse with the hyaluronic acid mouth rinse and just keep the area clean in general. I do not believe in prescribing Paradex rinses in these situations because Paradex has been shown to be cytotoxic to cells. So last thing I want is a rinse that's going to kill cells that I'm trying to use for the regenerative capabilities. So bottom line is I don't try to do a whole lot. I'll just try and babysit this thing along, call the patient back after another week or two, and by then the area has usually resolved itself.
Great. And I will combine these two. Have you had the opportunity to take a core from any of these sites grafted with the protocol you showed and see it histologically? And then follow up to that is on the first case, did you use any PRP or growth factors?
Okay, answer to the first question. That question must have been asked by an academic who's reading my mind, because that is the next step that I want to do is go into a regenerated site, take a core biopsy, because I'm actually in the process right now of writing up a case series of my Zmatrix cases. And so I think that showing a core biopsy would be very valuable. So I've not done it, but I'm going to. PRF or PRP, I generally don't use that as part of my protocol. So I don't think it really makes a huge difference to the healing. And again, with PRF, PRP, it's only as good as the patient that it comes from. So if the patient is healthy, there'll probably be some benefit. But just with the horizontal GBR technique alone, I don't think that it really enhances the healing per se if you stick to the basic surgical principles.
Okay, and last couple questions here. If you can't achieve primary closure, would you be comfortable leaving a collagen membrane like this one exposed, or would you use PTFE, or would you opt for some other type of protocol?
So if I couldn't get primary closure, which is rare, knowing the different flap techniques that we have at our disposal, but if I absolutely can't get primary closure, I don't like leaving collagen membranes exposed right from the get-go, because I find that they degrade relatively quickly and incite an inflammatory response. So what I do in those situations is I'll use an amnion chorion membrane over top of the collagen membrane just as an added protective layer, because these membranes also have a lot of growth factors and factors that enhance healing and regeneration. So I would use an amnion chorion membrane over top of an exposed collagen membrane.
That's great. That answered several questions. This will be the last question, and I'm going to take some liberties here and assume what the question asker is meaning, but I want to know the difference in this this Zmatrix membrane versus the cytoplast membrane. And so it's a little confusing because there's cytoplast non-resorbable and then there's cytoplast collagen, the cytoplast RTM collagen. And so I think they probably mean the difference in Zmatrix versus cytoplast RTM collagen.
Right. So
if you're
I can tell you the
product.
Yeah, absolutely. I'm familiar. I've used RTM, and one of the reasons I got away, frankly speaking, from RTM was because I just didn't like the way that it handled and the way that you can manipulate it in the site. Right? It's a little stiffer, and so you really have to have like an extra pair of hands. Your assistant hold it down. You need to have stabilizing sutures or tacks to hold this membrane in place. The Z-Matrix has that perfect balance of being soft, but at the same time being just I would say having enough body to be able to manipulate it and drape it intimately without the need for stabilizing sutures and horizontal augmentation cases.
Well, great. We're about 2 minutes over, so we will stop it at that point. And once again, Dr. Bhide, I can't tell you how appreciative we are for you spending some time with us. Great presentation. Really appreciate your insight and your candor. And we look forward to doing this again with you and with everybody that's on the call. Thank you, everybody, and everybody have a great evening. Bye-bye.
Thanks again, guys. Have a good night.